Ladies and gentlemen, we have now reached the highlight of tonight's agenda, the prestigious C.G. Uragoda Oration, tonight delivered by Professor David Denning, Professor of Infectious Diseases and Global Health, University of Manchester, United Kingdom. I would now like to invite the President, Dr. Niranjan Dissanayake, to introduce the orator to this esteemed audience.
Good evening, distinguished ladies and gentlemen. It is indeed a pleasure and honor to invite Professor David W. Denning to deliver the prestigious C.G. Uragoda Oration. Professor David W. Denning is a distinguished expert in infectious diseases and global health at the University of Manchester, with over 40 years of clinical experience specializing in fungal diseases. He founded and served as a Chief Executive Officer of the Global Action for Fungal Infection from 2013 to 2023. An international advocacy NGO dedicated to ensuring universal access to fungal diagnostics and antifungal therapies. From 2009 to 2020, he led the UK's National Aspergillosis Centre in Manchester. It's almost, it is the world-renowned center that we look up to, managing an annual budget of approximately 7 million Great Britain pounds. He's a prolific researcher. Professor Denning has authored over 800 academic publications, contributing significantly to the field with an H index of 137 and over 110,000 citations. He has played a key role in developing international guidelines for the diagnosis and treatment of serious fungal diseases. Additionally, he leads the leading international fungal education life, an initiative aimed at improving patient outcomes through online education. His contributions extend to the commercial sector, having founded 2 university spin-out companies, F2G, which developed a novel antifungal currently in phase 3 trials, and Myconostica, the pioneer in commercializing PCR tests for Aspergillus and Pneumocystis detection. He also served as the managing editor of Aspergillus website since 1998. He will be delivering the Uragoda Oration on a conundrum that we face on a daily basis. And without much deliberations, I would like to kindly invite Professor Denning to kindly accept the medal for the oration and proceed with his oration.
So I'm very aware that I'm standing between you and a drink or something to eat. So I will be brief as best as I can be, although I wasn't expecting us to be a little as late as this. It's a real privilege to be here. Thank you very much for the invitation. I do very much value it. I'm going to talk about this disease, which was first described in 1842 in Edinburgh by Dr. Bennett. The first radiology image of an aspergilloma was in 1938 from Rouen in Paris by Deve. The first treatment of this disease with amphotericin, which works, was in Michigan, in Ann Arbor, by Dr. Cummington in 1959. And the first serological tests for this disease were developed at the Brompton Hospital in the early 1960s by Dr. Jack Pepys. And I'm going to update you 65 years later about where we are with a disease that many people don't know much about. And it is a pretty complex problem. But first, I need to go to speak, if I can get this to work. Oh, am I doing the wrong one? I'm clearly doing the wrong one. Is it this one? Oh, sorry, I'm trying to get to the next slide. Where do I shine it? No, what was I not doing right? Okay, so I never had the privilege. So I never had the privilege to meet Dr. Uragoda, but I think he's clearly a father figure for medicine in this country, with a particular focus on pulmonary infections and occupational lung disease. He graduated from the Ceylon Medical Academy faculty in 1953. He was the physician in charge of the Central Chest Clinic in Colombo, then moved to Wellisara, which is now a National Hospital for Respiratory Diseases. His first publication that I could find was in 1959, and it was on the surgery of tuberculosis. And his last publication was on the impact of preparing chili as an occupational lung disease. And he's written multiple chest textbooks. But I want to call out one of his publications because it's relevant to my field, that is to say, histoplasmosis. So he did the one and only survey of exposure to Histoplasma capsulatum, an airborne fungus which is endemic in Sri Lanka. And this graph on the left-hand side shows the skin test reactivity, so much like a skin test, a Montu test for TB. And you can see some very strongly positive reactions from all of the red areas in your country. And interestingly, he never actually described a case of this disease. The two people who worked with me in Manchester and trained in mycology, Dr. Shumithra and Dr. Pramali, who co-authored this review, noted that, and it was a bit of a surprise to us. So Dr. Uragoda had many other accolades. He was president of multiple organizations that you can see here. I won't read them all out. He was a joint editor of the Ceylon Medical Journal for 20 years. He was editor of the Journal of the Ceylon College of Physicians, of the National Academy of Sciences Journal, and he was on the WHO expert panel for TB and chest diseases for 20 years. And he has a long list of distinguished accolades. This is a true giant of medicine, and you, I think, have been very fortunate to have him amongst your fraternity for so long in this country. Now I want you to meet a patient of mine called Roger. Roger was he was from Manchester, but he was living in Vancouver, and he was the first and only referral that I've had from Vancouver. He came with this infiltrate to the physicians in the Peters Hospital in Vancouver. And those of you who look after these types of patients would look at a lesion like that and be suspicious about malignancy because he was a smoker or TB or something, and they did a CT scan, and you have a spiculated infiltrate there. And so clearly this needs surgical exploration. And this was in December 1991, and they did a right upper lobectomy, and the pathology showed a small cavity with a granuloma. They thought it might be TB, they weren't sure, and a few Aspergillus hyphae in it. So they treated him for tuberculosis, and he decided to come back to the UK. And that was when he was referred to me. And nearly a year later, he developed a new cavity in what was his right lower lobe, now in his right upper chest. And we didn't know what this cavity was. Is this invasive aspergillosis? Is this cancer, which has appeared in a new place? Is it TB? What is it? So we put a needle into it, and we had a pure growth of Aspergillus fumigatus from it, and he had a strongly positive Aspergillus antibody. So, what is the diagnosis? Is he got an aspergilloma? No, because there's no fungal ball, right? What is this disease? And I was not clear. I knew a lot about aspergillus. I read the literature, and I still didn't know what was wrong with this man. And so, with his case and another 17 cases, I wrote 10 years later a paper describing this entity in non-immunocompromised people with cavitary disease, usually of the upper lobe, usually unilateral, but sometimes bilateral. And Roger was case number 2. and he was a smoker with a mild degree of airflow obstruction, this right upper lobe lesion. And here he is many years later on voriconazole. And as many of you know who've used voriconazole, it gives you a photosensitivity and you can go bright red. And he was bright red with the drug. And he managed it for about 7 months before he stopped. But he was one of the first 5 patients in the world treated with voriconazole. And we coined the term chronic cavitary pulmonary aspergillosis to follow the nomenclature of histoplasmosis and coccidioidomycosis. The previous terminology was developed by the surgical fraternity, and they had simple aspergilloma or complex aspergilloma. But if you don't have an aspergilloma, what is it? And the evolution of this disease radiologically was rather remarkable. So you can see at different time points, he developed really quite a lot of change within this area of cavitation. These are years apart, these images. And we finally got control of his disease after itraconazole, which originally failed, amphotericin, voriconazole, and then 5 years of itraconazole, long term. And he was stable, he was completely well. He would come to clinic 3 times a year. He would say he was fine. We would do his x-rays and imaging. And we thought, do we really need to carry on with this drug, itraconazole? So we stopped. He was immediately relapsed. And his CRP and ESR went up. They're not always raised in patients with CPA. His aspirus precipitants went up. That's a key element of diagnosis and following therapy. The titers, if they're done well, are very helpful. And we put him back on itraconazole. And Roger then ended up with about 30 years duration of antifungal therapy. 30 years. I don't know how often you've treated patients for that long with anything, apart from blood pressure tablets or insulin, but that's a long time. So switching gears, about a year ago, I published a paper in Lancet Infectious Diseases trying to estimate how many fungal infections there are in the world. And this was not easy. Nobody had really done it before in any systematic way. And probably there are about 6.5 million new patients with different forms of fungal infection. About 3.8 million deaths of about 2.5 attributable. So clearly, if you have leukemia, which relapses, and you no more treatment available, and then you get aspergillosis and die, that's probably not an attributable death, right? That's a leukemic death. But there are many patients who die of the fungal infection directly. This would not have been possible without all of the inputs which we have had through Gafi, through all the ambassador network, and you'll notice that Primali's face is on here for Sri Lanka, as contributors of many sorts to the global effort to get fungal disease better recognized at the WHO and other things. And this is one of the ways of summarizing that data, and I'll talk about this in a little bit more detail on Tuesday. But in chronic pulmonary aspergillosis, you can see there are probably about 1.8 million new patients a year across the world. That's modeled primarily on tuberculosis and missing the accurate diagnosis of TB, and probably about 1/3 deaths each year. So, as you know, there are a bit over 1 million, 1.2, 1.5 billion deaths from TB every year. Probably 300,000 of those deaths attributed to TB are not TB. They're actually fungus, aspergillosis. And we did this work in India in detail, and Dr. Candy might find this of interest because India has the largest population of TB patients on the planet, approximately 2 million cases a year and approximately 500,000 deaths. And we, with all the work that we've done across the world over the last 15 years on this disease, we think that there's probably about 200,000 initial misdiagnosis of TB. So 10% of the TB cases in India aren't TB. It's one problem. And then about 150,000 patients who develop CPA during the course of their TB or finish their and cured of TB, but are left with CPA, usually with cavities. And that gives an annual incidence, as you can see, of about 360,000. If you look at the patients who develop TB after many years or after they've recovered from their TB and been cured, you get cases every year, and there's probably about 1.5 billion in India. And probably about 140,000 deaths. It might be slightly lower than that because we've re-looked at the mortality figures, and it's a little bit less for TB because some of the patients are younger, but it's still a lot of people who are probably misdiagnosed. You have less TB in Sri Lanka, but around 14,000 cases of all forms of TB and about 800 some deaths each year. And if you look at the number who are tested with rapid diagnostics, only 27%, which is not a very high figure compared with some of the other countries in the world, 74% pulmonary, but notably 75% are confirmed cases of TB and 25% are not. Now, sometimes that's because the patient can't produce sputum and you can't bronchoscope the patient, or they disappear or whatever, but sometimes because they have negative tests. And in that group, probably about 20%, maybe a few more, have aspergillosis. So that's several hundred cases a year which need to be diagnosed and picked up. But it's more complicated than that. And this piece of work from Pakistan, and there's an excellent group at the Aga Khan in Karachi who've looked at this disease and really understand it quite well. And you can see that there are patients with previous tuberculosis coming up in their group. This is not just CPA, this includes invasive disease and other things as well. But 39% had previous TB, but 13% had active TB at the same time. So you can have CPA and TB. And we've done some work in Indonesia, and I haven't got the slides showing that that's particularly true for MDR TB, because they have a lot of cavitation with MDR TB, and cavitation is a big risk factor for CPA. And after you've been cured of your TB, you can then come back with CPA. And this study from Brazil, not a very big study, looked over 30-something years at when those patients came back. And you can see patients are coming back with CPA years and years, decades after they've been cured of tuberculosis. And other work we've done from Vietnam, from others have done in India, been done a little bit in Kenya and in Ghana. Over 50% of the people with possible recurrent TB who come back with symptoms have aspergillosis. 50%. So this group of patients is particularly tricky. And if they have very severe hemoptysis and you cannot operate, this small series in Brazil suggested you could give radiotherapy. It's the only series in the world suggested that, but it may be helpful. So there's also other things. There's atypical TB or NTMs. There's ABPA patients who get CPA, patients with COPD and emphysema, particularly if you've got bullous disease, upper lobe bullous disease, pneumothorax, lung cancer, sarcoidosis, thoracic surgery, and so on. And at the bottom, you will see a group of patients who have no underlying disease who just get aspergillosis. And the work that we haven't yet finished, we've been doing it for 10 years, clearly indicates there are genetic factors underlying this. We're fairly sure that it's a multigenic disease for many of these patients, and it's not manifest until later in life. So they present with symptoms you're familiar with, that is cough, shortness of breath, weight loss, tiredness, and the tiredness and fatigue is often quite profound in these patients. They're very, very tired, many of these patients. They cough up blood, more blood than with TB usually, not just a smear, but real blood. A bit of chest ache, but not pain per se, unless they've coughed too much and they've got a rib fracture. Only a few of them have fever. Fever is very uncommon. If they have fever, they probably have a concurrent bacterial infection as well. And the comorbidity is common. The hemoptysis is quite marked, as I've said. It's really quite a big deal, and some of them die of hemoptysis, so this does need addressing. But the other trick here is that many of these patients have almost no symptoms. This is a very quiet infection. It's not like pneumococcal pneumonia or severe COVID. This is very subtle. And so these patients come to clinic and you do a chest x-ray, you think, oh, they're all right. They're not complaining much. Go away, I don't need to do anything with you. And let me show you an example of that in a minute. And it's also really easy to mistake TB and CPA. Here are two x-rays where they look pretty similar. And if you haven't got a really good radiology support, or you're not sure, or you haven't got tests, it's really easy to just diagnose TB. And in many, many centers around the world, they have TB clinics, and they have 3 differential diagnoses. It's TB, TB, or TB. And the treatment for TB is free, and all the other treatments the patients have to pay for. So what do you diagnose? TB, and you treat them for TB. So this is part of the sort of problem with the disease. It's not enough thought. You shouldn't have that problem here, because you do have this. So there are different patterns of disease. There's the simple or single aspergilloma. There are patients with nodules, which can look like lung cancer. There are patients with subacute invasive disease who are a little immunocompromised, on some steroid, diabetic, or on a bit of chemotherapy for CLL or something like that, late-stage HIV. They need to be treated as invasive disease. The big group is the chronic cavitary group, sometimes with an aspergilloma, sometimes not, and those can progress to chronic fibrosing. So the simple aspergilloma, a young lady from Pakistan who came over, recently got married, coughed up blood, was otherwise quite asymptomatic, had not yet had a family. You can't take itraconazole and get pregnant. So she was fit and well. She had a lobectomy, cured. So this is great. But in our experience, it's about 5% of the patients. It's not very many of them, but it's great when it happens. And look at this lady who had a pneumothorax. She had a pneumothorax. This is post-pneumothorax 2012. And she comes back and she's fine. She's absolutely fine. A year later, she has a chest x-ray, which is not quite the same, as you can see. So her right lung is just a little not quite right, but she's asymptomatic. A year later, now the lung is not looking good at all. Asymptomatic. No action taken. Because in clinic, she's asymptomatic. So the young doctors that see her say, you're fine, off you go, you haven't got any symptoms. And that's what happened 4 years after that. And now she's got chronic fibrosing pulmonary aspergillosis, and she's lost the whole of the right lung. And so one of the key objectives of treatment in these patients is to prevent fibrosis. It's not just to treat symptoms. You're trying to prevent fibrosis and hemoptysis. And that's a big factor. And it's challenging, this. Radiologically, it's challenging. This patient happened to have a PET scan because they didn't know if he had cancer or not. And you can see it's lit up of his left apex. And this cavity in his left apex on the CT scan has got a big irregular edge, lots of irregularity in it. That's all fungal growth. The whole lot is fungal growth around that. And had we taken that out, this is what it would have looked like. All these plaques of fungus on the inside of that cavity. So when you see irregularity on a cavity, you have to think, is this fungus? Not a fungal ball, just irregularity. And if you do see a fungal ball, the prognosis is worse. And if it's bilateral, it's even worse again. This is some data from our center. So this man from India, living in the UK, he'd had TB twice, proven twice, treated twice, cured twice, except clearly not cured the first time. Then he comes with a new cough. He's working full time, he's busy, he's not actually too bad, but his chest x-ray has changed. So they then do an aspergillus antibody. It's strongly positive. Just to emphasize, an aspergillus antibody is the key test for this disease. That is the test that has to be done. All right, aspergillus IgG antibody. Normal CRP, normal plasma viscosity. So I told you this was a quiet disease. It is quiet from an inflammatory perspective as well. And then he had a CT scan, obviously, because there was a change in his chest x-ray, and he's got multiple cavities and some pleural thickening in that, in his right apex. And then they did a PET scan because they thought, oh, maybe he's got cancer. And you can see that this is a pleural inflammation disease. Loads and loads of pleural inflammation. And actually, if you look carefully, you can see 3 fungal balls on that PET scan. It's at about 5 o'clock on the top image. I need to put my glasses on for the other. I think it's about 2 o'clock in the next image down. And then the bottom one is about 10 o'clock. So he's got actually 3 fungal balls, these little gray areas which don't light up. And that's one of the problems we have, is actually seeing these things and knowing that they're radiologically is tricky. So 3 components of diagnosis: symptoms, except that not all the patients have it; radiology, which is tough to interpret; and aspergillus IgG antibody, which can be positive for other reasons. So you put all those three together, and then you end up with usually a confirmed diagnosis of CPA. But it's tricky. Some of the cases are not obvious, and it can be a difficult diagnosis. The European guidelines that we published in 2016 recommended that chest radiologists or radiologists in general, if they see images which look like TB, and there's pleural thickening or cavitation, they should also mention aspergillus in the report, so that the young doctor who doesn't never heard of CPA and aspergilloma thinks, oh, which test do I do for that? And they can ask a question and they can send an aspergillus antibody test. And that's one of the things that's missing across the world, is actually thinking about something other than tuberculosis. There is a lateral flow assay for this disease. It's come out of France. It works pretty well. This is a nice study from Chandigarh. There's another study from AIMS in Delhi, which shows not quite such good performance, but still pretty good. But I caution you that it's 86.7% sensitive. So that means 13.3% are falsely negative. Okay? So roughly 1 in 7, 1 in 8 are falsely negative. So labs need to do 2 tests. You need to have another test, and you also need to be able to take specimens for fungal culture, which are frequently negative, but they are there. And one of the things that we did do in Manchester was to look at how we did fungal culture. And if you take the whole specimen and you put it on a fungal plate, you get a much higher yield than if you just take a little bit of the sample and spread it out. So there needs to be a shift in mycology diagnosis with sputum. And we also know that if you take 2 or 3 specimens, just like the TB, you're more likely to grow the organism. So keep trying, keep sending a specimen, and ask for fungal culture. Don't just ask for culture, because bacterial plates don't grow fungus very well. They do grow it a bit, but not very well. You can also do PCR, or you can do a bronchoscopy, and you can do culture microscopy and an antigen test, aspergillus antigen test on the bronchoscopy fluid. And that's pretty good, about 60-70% sensitivity. Not perfect, but again, it's another way of reaching what can be a tough diagnosis. So we treat this with oral azoles. That's the usual standard treatment. Itraconazole is the standard treatment. Some of the patients are treated with voriconazole. And if the patients are really sick, then we can give them amphotericin, or we can give them caspofungin. And this very nice RCT from Chandigarh, led by Inderpal Segal, who working with Arunluku Chakrabarti and Rita Agarwal up there, looked at the duration of therapy, and they got a better response if you can treat for 12 months than if you treat for 6 months, and you also have a lower relapse rate. And so I talked to you about Roger, who relapsed after 5 years of itraconazole. Probably this 6 to 12 month dialogue is not really the right dialogue. Actually, it probably should be, can I get away with a short period of treatment of these patients and stop treatment and have them in remission for long periods off therapy? Or have I got a patient that's going to relapse a lot and I just need to keep going? And we haven't got there with the science yet. The evidence base is not there to sort that out in many ways. So I caution those of you who prescribe antifungals to be careful. There are loads of drug interactions, particularly with itraconazole and voriconazole, and these severe line across the top here are potentially fatal or drug interactions. So bedaquiline you can't give with an azole, for example, if you have an MDR-TB, because you get QTc prolongation. You can't give rifampicin with an azole because you have undetectable azoles. You can't give carbamazepine phenytoin with an azole because you have undetectable azole levels. So check, and this database, which is updated every week, and it's very comprehensive, is free to all, it's easy to find, and have a look at that and take that. And my last slide is for those of you who end up with surgery. You will have patients who you want to take to surgery, or patients with nodules or cavities. You're not sure what the right diagnosis is, and you want to take them to surgery. And if you think it might be aspergillus, if there's a possibility, give them antifungals before surgery and during surgery. If you wait until you've got a diagnosis afterwards, you can see quite clearly in this Kaplan-Meier that the relapse rate is much higher if you haven't given pre-treatment. And also, for those of you who work with the surgeons quite a bit, sometimes these things are quite difficult to get out because they're all stuck at the top of the lung. It's really difficult and you have to peel it off, and it's a very slow process. If the cavity ruptures during surgery and you end up with Asperger's in the pleural cavity, that's a patient that absolutely needs treatment, because otherwise you'll end up with pleural aspergillosis, and that's a really difficult entity to treat. So we wash that cavity out with amphotericin during surgery. We just get the pharmacy to make it up and bring it up before we close the chest or do anything. And then we really give the patient a lot of therapy if that cavity is ruptured during surgery. If it's taken out intact, then you can often get away with it. There's lots more I could say, but I won't. I think it's time for us to move on to the next phase, which is talking to each other and having a nice drink. Thank you very much indeed.
Thank you very much, sir, for your very enlightening talk and giving us much food for thought. Please accept this token of appreciation presented to you by the President of the Sri Lanka College of Pulmonologists.